Welcome to the deep dive. Today we're really getting into something crucial for vascular surgeons, mesenteric vascular disease.
That's right.
We're going to be pulling out the absolute must-knows from Section 20 of Rutherford's Vascular Surgery and Endovascular Therapy.
Specifically chapters 133 through 136.
Exactly. So think chapters on acute and chronic mesenteric ischemia, dissection, and median arcuate ligament syndrome, or MEL-NS.
Our goal here is basically to boil down these dense chapters into a practical guide, something actionable for diagnosis and management.
Yeah, sort of rapid-fire briefing. We know this stuff is complex, right?
Oh, absolutely.
Uh-huh.
But the aim today is clarity. Cut through some of the noise.
Okay, let's jump in. Chapter 133, Acute Mesenteric Ischemia, AL. This is the big emergency. What are the absolute essentials for a surgeon potentially facing this?
Right. First thing, AMI is popping up more, especially in older women, often with lots of other health issues. You've got to think about the three main causes.
A big three.
Yeah. Embolic, thrombotic, and non-occlusive, or NOMI. Embolic is often sudden, think atrial fib, maybe a recent heart attack, bam, clot travels.
Okay, sudden onset.
Thrombotic, though, that can be sneakier. Maybe the patient already had symptoms of chronic mesenteric problems like pain after eating, weight loss. It's often acute on chronic.
So a history might point towards thrombotic.
Exactly. And for both of those, embolic and thrombotic, the key is restoring blood flow, like yesterday.
And NOMI, that sounds different.
It is. No-occlusive mesenteric ischemia happens in really sick patients. People in shock, maybe after heart surgery, sometimes dialysis patients.
So not a clot.
No, it's more like the mesenteric arteries just clamp down hard. Vasospasm. It's often triggered by the body's stress response, shock, certain meds even. Recognizing that critical illness is key to suspecting NOMI.
Got it. Embolic, thrombotic, physical blockage. NOMI, physiological clamping down. So how does the bowel itself handle this lack of blood flow? I mean, what happens inside?
Well, initially the bowel is surprisingly tough. It can tolerate quite a drop in blood flow. It opens up extra capillaries, pulls more oxygen out of the blood passing through.
Compensatory mechanisms.
Right. But that only lasts so long. If the ischemia drags on, the gut lining, the mucosa, which needs a ton of energy, starts to break down.
And that's when things go south.
That's the turning point. You get inflammation, bacteria can leak out. Early signs might just be trouble absorbing nutrients, maybe some blood in the stool, heme-positive diarrhea. This window, before it's totally dead, is crucial for intervention.
So the clock is ticking, even if the symptoms aren't dramatic yet. What are the clinical red flags for AMI?
That's the tricky part. Early on, it's often just vague stuff, diffuse belly pain, feeling sick, maybe vomiting. The classic pain out of proportion to exam findings is a later sign, really.
Tenderness means it's progressed.
Usually, yeah. Significant tenderness often points to transmural ischemia. The whole bowel ball is suffering. Sepsis signs mean necrosis. A really abrupt, severe pain might suggest an embolus. Thrombosis, maybe more gradual. NOMI is the wild card, often a very unpredictable course.
Vague pain in a high-risk patient definitely raises suspicion then. What's the go-to diagnostic tool now?
It's really shifted. CT Angiography, CTA is a workhorse now. It used to be angiography, but CTA is available 24/7. It sees the vessels, the bowel wall, and it can spot other problems that might mimic AMI.
It's pretty accurate.
Very high sensitivity and specificity. And doing a biphasic scan, arterial and delayed venous phases, gives you even more info, like about the portal vein and how well the bowel wall is perfusing.
Okay, so CTA is key. What findings on the scan scream AMI?
You're looking for changes in the bowel wall thickness. Sometimes it's thick, sometimes thin. Air in the bowel wall, that's pneumatosis intestinalis, a bad sign.
Right.
Gas in the portal vein is another ominous finding. Clots in the mesenteric veins, weird contrast enhancement patterns in the bowel, all clues.
And other imaging. MRA, angiography.
MRA isn't usually fast enough for the acute setting. Angiography still has a role, maybe if CTA isn't clear, especially for NOMI and definitely now for guiding endovascular treatments. Duplex ultrasound, more for chronic disease, less helpful acutely.
Okay, we have the diagnosis, AMI confirmed. What's the immediate game plan?
3 pillars, really. 1, get blood flow back ASAP for embolic and thrombotic disease. 2, cut out any dead bowel source control. 3, aggressive critical care, especially vital for NOMI.
Restore flow, resect, resuscitate. Let's break down that initial care.
Fluids, crystalloids, fix electrolytes, start broad-spectrum antibiotics right away, heparin drip, therapeutic dose to stop clots getting worse.
What about blood pressure support, vasopressors?
Use them cautiously. Try to pick ones that don't clamp down too hard on the gut circulation, low-dose dopamine, dobutamine, milrinone maybe. Avoid pure alpha agents like phenylephrine if you can.
And for NOMI specifically?
NOMI treatment is mostly about fixing the underlying problem, improve cardiac output, get them off offending drugs, optimize fluids. Trying to directly dilate the mesenteric arteries with drugs via catheter isn't really standard practice anymore. The evidence is shaky, and it can drop their pressure dangerously. Surgery for NOMI is only if you suspect gangrene.
Right. Now, for the blockages embolic or thrombotic, what are the open surgical options?
Okay, for an embolus, often it's an open embolectomy. Make a small cut in the artery, transverse arteriotomy usually. Use a Fogarty balloon catheter, maybe a 3 to 5 French proximally, smaller distally to pull the clot out.
What if you can't get the catheter down?
You might try gently milking the vessel. Sometimes you might even use a bit of TPA directly into the artery if there's clot stuck way down. For thrombosis, especially if there's a lot of underlying plaque, you often need a bypass.
Bypass, how's that done?
You expose the SMA, usually coming in from the side, lateral to the duodenum. Inflow where the blood comes from for the graft is key. Emergently, the common iliac artery is often easiest for a retrograde bypass graft.
Retrograde meaning flow goes sort of backwards up to the SMA.
Exactly, a lazy C-shaped graft. Or you could use the infrarenal aorta. Antegrade bypass from the aorta above the celiac artery is another option, maybe better hemodynamically, but it's tougher. Involves clamping the aorta higher up.
Graft type. Anastomosis.
Usually prosthetic, like Dacron or PTFE. An end-to-end anastomosis between the graft and the SMA often lies better than end-to-side.
Okay, that's open surgery. What about endovascular? Less invasive options.
Yeah, percutaneous stenting can restore flow quickly, especially for blockages right at the start, the ostium. Covered stents are generally preferred for chronic disease for better patency, but in AMI, with potentially necrotic bowel, there's an infection risk to consider.
So maybe bare metal stents sometimes?
Could be. Angioplasty alone usually isn't enough. It tends to restenoze. There are also devices for sucking out or breaking up clot percutaneously, basket retrievers, thrombectomy catheters. Less invasive than open embolectomy, but you do risk sending clot fragments further downstream.
All right, distal embolization. And the chapter mentions a hybrid approach, ROMS.
Retrograde open mesenteric stenting. It's a mix. You do an open operation to expose the mesenteric artery, usually the SMA, get control. Then you puncture the artery distally, feed a wire and sheath back up towards the origin, and deploy a stent under X-ray guidance.
When would you use ROMS?
It can be really useful for flush occlusions right at the takeoff of the vessel, or if the patient's anatomy makes a purely percutaneous approach or a standard bypass tricky. Success rates are pretty good, but like other endo stuff, restenosis can happen, so you need close follow-up with duplex scans.
Makes sense. So you've restored blood flow, either open or endo. How do you know if the bowel is viable? And what about the second look?
Generally, you revascularize first. Give the bowel a chance to pink up now that it has blood flow. The exception is obvious perforation or free air on imaging.
Yeah.
Then you have to resect that segment immediately for source control, then revascularize, then reassess.
And if it looks totally dead from the start?
If it seems like the entire bowel is necrotic, revascularization might be futile. Sometimes the difficult decision is just to explore and close. But usually you revascularize and plan for a second look operation, typically 24 to 48 hours later.
Go back in to check.
Exactly. You directly look at the bowel again, see what recovered, what didn't, and resect any segments that are clearly non-viable.
Any tricks during surgery?
Yes, sir.
Vasodilators.
You can use papaverine dripped directly into the SMA to combat local vasospasm. Glucagon intravenously has shown some benefit in animal models, but human data is limited and it can cause hypotension, so you need to be careful with volume status.
And long-term, after they survive AMI.
Lifelong surveillance is key. Duplex ultrasound is the main tool to check graft or stent patency. Get a baseline scan soon after the intervention, then maybe 6 months, 12 months, and annually after that. If symptoms come back or velocities spike on the duplex, you'll need contrast imaging like CTA again.
Okay, that's a lot on AMI. Let's shift gears to Chapter 134, Chronic Mesenteric Ischemia, CMI. This is more of a slow burn, right?
Exactly. CMI is about supply and demand. The blood supply through narrowed arteries is okay at rest, but it can't meet the increased demand after eating. It's like angina of the heart, but in the gut, intestinal angina.
And it takes significant disease.
Usually, yes.
Uh-huh.
Because the gut has such rich collateral blood supply between the celiac, SMA, and IMA, you typically need significant stenosis or occlusion in at least 2 of those 3 main arteries to get symptoms. Though sometimes severe SMA disease alone can do it. Symptom severity depends on how bad the blockages are, how quickly they developed, and how good those collaterals are.
What happens if CMI just progresses?
Well, the big worry is progression to acute mesenteric ischemia, especially if they have vessel disease. That risk is a major reason why we consider intervening early in symptomatic patients.
So what are the classic symptoms we should listen for in CMI?
The classic triad. 1, postprandial abdominal pain starts usually 10-15 minutes after eating, lasts maybe hours, often mid-abdomen. 2, weight loss, often pretty significant, unintentional. And 3, food fear. They actively avoid eating because they know it will hurt.
Food fear. So they just stop eating much.
Pretty much. They adapt, eat tiny amounts, which leads to the weight loss, sometimes severe malnutrition or cachexia. That weight loss is a really strong indicator for intervention. Interestingly, if someone has the postprandial pain but no weight loss, revascularization might not actually help them.
Any other symptoms?
Sometimes nausea after eating, vomiting, maybe diarrhea. And watch out for subacute mesenteric ischemia. That's when the pain goes from intermittent after meals to being constant over days or weeks. That needs urgent evaluation.
What about the physical exam?
Often not very helpful, honestly. They might just look thin. Maybe you hear an abdominal bruit in about half of patients. A full vascular exam is important, though. Check for peripheral artery disease elsewhere. Lags are usually normal. Keep in mind, atypical presentations exist vague pain, changes in bowel habits, plus weight loss.
Diagnosis seems heavily reliant on the story then. What imaging confirms it?
Non-invasive imaging is key for planning. CTA and MRA both work. Most surgeons lean towards CTA now because it shows calcium, thrombus, vessel size really well. It might even replace duplex ultrasound as the first test if the symptoms are classic CMI. Duplex is good for spotting high-grade stenosis in the celiac and SMA, non-invasive, but it's very operator-dependent.
So duplex maybe as a screen, CTA for detailed anatomy.
That's a common approach. Contrast arteriography is mostly just done now if you're already planning an endovascular fix or if the C-TAMR wasn't clear.
Okay, diagnosis made. What are the treatment goals for CMI?
Simple goals, really. Stop the pain, let them eat and gain weight, and prevent it from turning into AMI. How and when you intervene depends on how bad the symptoms are and the patient's overall surgical risk.
Medical therapy alone.
Maybe short-term, like bowel rest and IV nutrition to stabilize someone very malnourished before intervention, but long-term non-operative management usually isn't the way to go. SVS guidelines basically say revascularize symptomatic patients with those key features: weight loss, food fear, pain, diarrhea.
And the options. Endo versus open again.
Yep. Endovascular angioplasty and stenting is often the first approach, especially for osteolesions. Covered stents seem to have better long-term patency. Usually fixing the SMA is a priority, even if other vessels are involved.
When would open surgery be preferred?
If the anatomy is really challenging for endo-heavy calcium, long blockages, tiny vessels downstream, or if endo has failed before, the SVS suggests open bypass for lower-risk patients with that kind of unfavorable anatomy.
The open options sound similar to AMI, bypass endarterectomy.
Pretty much. Antegrade bypass from the supraceliac aorta, retrograde bypass from the iliacs or distal aorta, transaortic endarterectomy for lesions right at the origin of celiac and SMA. ROMs can be used here too. Choice depends on the patient, the pattern of disease, surgeon preference. And again, checking the repair intraoperatively with angiography or duplex is important.
Got it. Moving on to Chapter 135, Mesenteric Arterial Dissection. This is an atherosclerosis, right? It's a tear in the vessel wall.
Exactly. Isolated splanchnic artery dissection, or SIVAD. We're spotting it more often now thanks to better CT scans. The SMA is the most common one affected.
Why do these happen? What causes the tear?
It's still debated. For the SMA, a leading theory involves hemodynamic stress, shear forces, right where the artery transitions from being fixed near the aorta to being more mobile further down.
Makes sense mechanically.
Other ideas include bleeding within the vessel wall from tiny vessels called vasa viscerum, maybe some underlying weakness in the artery wall, even a possible genetic link. For celiac artery dissections, the cause is even less clear.
How do patients present? Is it always dramatic pain?
It varies hugely. Some are found incidentally, completely asymptomatic. Others have severe, sudden, tearing abdominal pain, maybe radiating to the back. Nausea, vomiting can happen. That pain out of proportion finding can be a clue here too. The range of presentations makes it tough.
Diagnosis. Still CTA.
Yes, CTA is king here. It can show the dissection flap, the false lumen, any clot, intramural hematoma, or even complications like aneurysm formation or rupture. Over 95% are diagnosed this way now.
The chapter mentions classification systems, Sakamoto, Yun. Are they useful in practice?
They try to categorize the dissections based on things like whether the false lumen is clotted or open, if there's re-entry. The idea is to help predict risk and guide treatment, like maybe certain types are safer to watch conservatively. But their real-world utility is still evolving. The studies often have small numbers.
Okay, so how are these treated?
For asymptomatic patients found, incidentally, the consensus is medical management. Maybe antiplatelets or anticoagulants, though the evidence for that isn't super strong.
And if they have symptoms? Pain.
If there's no sign of bowel ischemia or rupture, the initial approach is often conservative. Bowel rest, IV fluids, pain control. Some advocate for anticoagulation short-term, but again, it's debated. Many patients actually do well with this. The dissection can stabilize or even heal on imaging.
So observation first.
Often, yes, with close monitoring. If the pain persists or worsens, or if there are signs of ischemia or aneurysm development, then intervention is needed.
What kind of intervention?
Endovascular stenting is often the first choice. The goal is usually to cover the entry tear, close off the false lumen, and restore normal flow through the true lumen, especially if the false lumen is compressing it. Self-expanding bare metal stents are often used.
And open surgery.
Reserved for complications worsening pain despite other attempts, bowel ischemia, rupture, aneurysm formation. Options include bypass grafting around the dissected segment or sometimes ligation, and definitely need follow-up imaging after treatment, usually CPA, to watch for late problems.
Okay, one more chapter. 136, Median Arcuate Ligament Syndrome, MELO-LS. This
Yeah.
one seems controversial.
That's a good word for it. MELS is compression of the celiac artery by the median arcuate ligament, a fibrous band from the diaphragm. But the controversy lies in figuring out who actually has symptoms because of this compression, since many people have it anatomically without any problems.
So the compression itself isn't always the issue.
Exactly. And the thinking is shifting. It might not be just about blood flow restriction to the gut. There's growing focus on a neurogenic component compression of the celiac plexus nerves that run right alongside the artery.
Nerve compression causing pain.
That's the current leading hypothesis for many. The ML compresses the celiac ganglion, which has pain fibers, and also nerves controlling stomach motility. This might explain the epigastric pain, nausea, vomiting, especially after eating or exercise.
How do you diagnose MELS if it's so tricky?
It's tough. History is key, that postprandial or exertional epigastric pain, maybe nausea, weight loss, then imaging. CTA, often done with views in both inspiration and expiration, can show the celiac artery compression by the ligament, sometimes with poststenotic dilation.
Does it look different when they breathe?
Yes, the compression is typically worse on expiration when the diaphragm moves down. Duplex ultrasound is also very important here. It can measure blood flow velocities in the celiac artery during breathing. Velocities often shoot up dramatically during expiration if the ML is compressing it.
Specific velocity criteria.
Yeah, things like peak systolic velocity over 200 centimeters on expiration that improves with inspiration, or even higher velocities are suggestive. There are more complex criteria too, looking at angles and diastolic flow, but no single finding is perfect.
What about treatment? Can you just stent the celiac artery?
Generally, no. Just stenting the artery without releasing the external compression doesn't work well. The stent can get crushed or fractured. The mainstay of treatment is surgical release of the median arcuate ligament.
What the ligament?
Exactly. And crucially, also dissecting and releasing the celiac ganglion nerve tissue around the artery. This is usually done laparoscopically now, sometimes with robotic assistance. The idea is to decompress both the artery and the nerves.
Does that work?
For carefully selected patients, yes. Laparoscopic release can provide significant symptom relief for many, but patient selection is everything. If you operate on someone with the anatomic compression but whose symptoms aren't really due to MELS, they likely won't get better. Some studies show good immediate relief, but recurrence can happen.
So it's really about linking the symptoms directly to the compression and likely nerve irritation.
That seems to be the key. Just seeing the compression on a scan isn't enough. You need the right clinical picture. There's even speculation linking mouse nerve irritation to other conditions like POTS. It's an evolving field.
Wow. Okay, that covers a huge amount of ground across mesenteric vascular disease. From acute life-threatening ischemia to chronic pain syndromes and these more debated conditions like MELS.
It's a complex area, definitely. But having this foundational knowledge from Rutherford's is vital for any vascular surgeon. Understanding the different presentations, the diagnostic pathways, the treatment options, both open and endo, is crucial.
And the field keeps changing, right? Especially with endovascular techniques and maybe our understanding of things like mals.
Absolutely. Techniques are constantly being refined, and our understanding of the pathophysiology, particularly the neurovascular interactions, is growing.
Which leads to a final thought, perhaps. As we learn more about how vascular anatomy and nerve networks interact, like in MELAS, what kinds of new diagnostic tools or even therapies might we see down the road for these complex mesenteric disorders? Something to think about. Thanks for joining this deep dive.